Hello and welcome back to MedCamps. This is the ultimate MMI interview series and we're going to start with medical ethics now. You may notice change of the usual red studio. Well, I'm at home now, I'm not at university anymore. So yeah, I'm going to be doing this from my room. But yeah, we've got to get you through the interview. So let's just get cracking. So today there's going to be some illustrations coming up on the screen wherever there's space and just illustrating what I'm saying because I'm going to be speaking through a lot of concepts and they're going to be quite tricky to follow. Let's get started. We're going to talk about medical ethics. Now, in medical ethics, I want you to know the 4 pillars of medical ethics, and you might have heard of these before. They're called autonomy, beneficence, non-maleficence, and justice. And there's a bit that we're going to speak about each one as I go along. But first, let's just go through the 4 medical ethics, and then after that, we're going to talk about consent and capacity, and we're also going to touch on confidentiality too. Some people put that as part of the 4 medical ethics as a 5th pillar or as part of autonomy, but it's best to keep that tool separate. And I say tool because these are all going to be like tools in your arsenal when it comes to medical ethics questions. Medical ethics questions in your interviews are really easy to answer once you've got your structure down. So it's really good to prepare for these questions beforehand. If you're going to prepare for any question out of your medical school interview, definitely prepare for the medical ethics ones and the ones that you can answer using the work experience diary too. Those are really important as well. I wouldn't say medical ethics questions are more important than the other questions because, it's just one out of all the questions you're going to be asked. And sometimes they just don't even ask any ethics questions as well. So they kind of anticipate that a lot of students do the reading and sometimes they might not even ask it. But in the event that they do, you need to shine above other people. Other people are going to know the 4 pillars of medical ethics and that's about it. You're going to need to step that up and know the 4 pillars of medical ethics: consent, capacity, confidentiality, the rules around each of those, and then a law here or there. In order to answer your medical ethics questions in interviews, one of the really important things you need to remember is structure to your answer. I don't care what scenario they give you, you can use your structure and pick it apart, analyze it, and get all the marks you need. Remember, they're not assessing you on what conclusion you reach at the end. Okay, they're assessing you on how you reach that conclusion and what medical principles or ethical principles did you use to get to that conclusion. So, the structure is this. You define your medical pillars, which we're going to talk about. You apply the medical pillars to the scenario in question. So you say, if I was to prioritize autonomy in this scenario, I would do action X or Y or whatever it is. Then you come up with a few consequences on both sides of the argument for any of the medical pillars. You weigh up a few pros and cons. And then after that, you apply the, I call accessory kind of principles in your medical school interviews, which is confidentiality, consent, and capacity. If any of those are applicable to the scenario, you apply them. Okay? Then after that, you come up with your own personal judgment of what you would do in that scenario. Something as simple as, due to the things I've discussed, I would do X. And then just leave it at that. Then there's no right or wrong answer, but you've shown all your reasoning and then you just pick whatever you think is right. You're not going to get marked down on what you chose, whether it's allowed or not allowed or whatever. They're marking you on your reasoning, right? So that's the structure to which you should approach a medical ethics question. Now, as I continue on with the video, you'll be able to fill out that structure with theory. So you'll know what the medical ethics pillars are. You'll know how to apply them. You'll know how to weigh them up, pros and cons. You'll know how to apply consent, capacity, and confidentiality to the question. And then you'll be able to come up with your own personal judgment. And you'll get full marks. And not only full marks, you'll do way better than the other students. In every other video I've seen on YouTube for 4 pillars of medical ethics and things like that, they don't go into much detail on capacity. They definitely don't go into much detail on confidentiality as well as consent as well. So I go into quite a lot of detail in this video. So keep up as best as you can. Make notes. Go over this video twice or 3 times over. Make sure you're smashing these stations out of the park. These should be really easy marks for you to get. It's a shame if you don't get these marks because they're literally free marks for you if you just prepare properly. The first pillar of medical ethics is autonomy. Autonomy putting it very simply, is respecting the patient's own free will and decision. So if I was to give you a scenario of a Jehovah's Witness requesting a blood transfusion, which is against their religious beliefs, and they instead request EPO products, which are much more expensive than blood transfusion, then is it right to spend that extra money on the Jehovah's Witness? If you're valuing autonomy above the other 4 pillars, which I'm going to mention in a bit, then you would follow with what the patient's own wishes are. And in this case, it's to have the EPO products and not the blood transfusion. Sticking with the same scenario, let's move on. So, beneficence. Beneficence is the next pillar of medical ethics, and beneficence basically means to do good by your patient. Doing good for your patient could be summarized in the key term that you're going to hear a lot throughout this video: best interests. What is in the best interest of that patient? Now, be very careful. Don't assume that what they want is then what's in their best interests because they want it. You're muddling the lines between autonomy and beneficence. The best interests of a patient is what's medically the best interests for them. So therefore, if you're considering what's in the best interest of this patient, let's say there's no EPO products at hand and they need the blood transfusion urgently. In their medical best interests, it would be to give the blood transfusion. We're going to come back to talking about best interests because there's something called the best interest standard. And how do we define what is in a patient's best interests? Who are we to say that? We need to be able to prove that in a court of law if you're ever questioned on it. But swiftly moving on to the next pillar, which is non-maleficence. So we've talked about autonomy, we've talked about beneficence, which is doing good for your patient. Now we're going to talk about non-maleficence. Non means not, and maleficence means harm, pretty much. So we're trying to prevent or minimize harm to the patient. This is non-maleficence. Now, the difference between doing good for your patient and not doing harm to your patient is quite subtle in certain scenarios. So in this scenario, you'd think doing good for the patient is giving them blood transfusion because it's medically in their best interests. Well, that's in the patient's best interests. But if we extend the patient out to their family and friends in their community, which is part of the patient's life as well, we might be doing harm to that patient's life in ways that we won't see immediately in the hospital, because their friends and family may be disapproving of their decision or of what treatment they chose. This is non-maleficence, so we're trying to minimize the harm that's done to that patient in any manner possible, whether that's social, psychological, or biological. Now, non-maleficence is wider in scope than beneficence is. Beneficence, 95% of the time, only focuses on the patient. Okay, so you're doing good for your patient. Non-maleficence can be minimizing harm to friends and family as well. Now, an example I like to use to illustrate non-maleficence is the example of a HIV patient who's infectious and they refuse treatment. In addition to that, they also refuse you telling their sexual contacts that they have HIV and that the sexual contacts should get tested and treatment as well. So you're now in a conundrum. Do you break patient confidentiality and notify his or her sexual contacts in order for them to get treatment too? Or do you respect the patient's wishes and keep it confidential? So here, the pillar of non-maleficence pretty much says that we should minimize or prevent harm as much as possible. In this scenario, that would also apply to his or her sexual contacts. So we would therefore, if we're following the pillar of non-maleficence, we would notify his or her sexual contacts in order to prevent harm to them as well. So putting it simply and wrapping up in something you can write in your notes, non-maleficence has a wider scope than beneficence, and it could include third-party members. Between beneficence and non-maleficence, a way to distinguish between them two: beneficence is a positive rule. You're giving positive result to the patient. And non-maleficence is preventing the negative. So you're minimizing or preventing harm to the patient. So it could be simply wrapped up that beneficence is a positive rule and non-maleficence is a negative rule because you're preventing something. Okay, quickly going back. So we've done autonomy, beneficence, non-maleficence. Now the last one, justice. There's 3 different types of justice, but I'm going to focus on two mainly. The third one you're never really going to need to know, but it's just if you want to show off a little bit. So the three different types are legal justice, which is the most important one, which is concerning the law. Second one is distributive justice, which is important in the case of the Jehovah's Witness. Distributive justice encapsulates the term equity. So I don't know if you've ever seen the picture of the people looking over the wall comparing equity and equality. The way I like to illustrate equity versus equality is if we have three pirates and one of them has scurvy severely, one of them is slightly symptomatic for signs of scurvy, and the other one doesn't have scurvy at all and is not showing any signs. And I have three oranges. If I was following equality, I'd give each person an orange to keep it equal distribution. If I was following equity, i.e. trying to aim for an equitable distribution of my resources, I'd give 2 oranges to the person who's very symptomatic, 1 orange to the person who's slightly symptomatic, and none to the person who's not showing any signs. That is the difference between equity and equality. So, and this is Aristotle's principle. I'm not going to bother boring you with fluffy philosophy because you won't need to know if you interview, but we're aiming for an equitable distribution of resources. That's distributive justice. So in this case, do we see the Jehovah's Witness as in need of the resource of the EPO products because they're expensive and they'll cost us a lot? Or are we detracting from other patients? Funding that could be applied to other patients' care as well. So is this fair? Keyword fair, not equal. If it was equal, we'd only give the Jehovah's Witness what the equal distribution would be. But that's not how it works in the NHS. Another key thing to know about distributive justice is the NHS actually have a system of being able to vet out whether an intervention or a treatment or a campaign across the UK is actually worth the money it requires. The way they do this is they assign something called a QALY to a treatment. Let's say it's a drug, right? They assign a QALY to a drug. What does QALY mean? QALY, QALY, is quality adjusted life year. Quality adjusted life year pretty much means how much quality of life do you gain in years for this treatment. So for this treatment, for every 1 quality of life year gained, the NHS will put a maximum price that they're willing to spend on that 1 life year gained between £20,000 and £30,000. Okay, so that's their spending limit. Anything above £30,000, it's very rare that the NHS will invest into it. So that's just some background knowledge on distributive justice. And whenever questions come up about resource allocation in the NHS or questions about the NHS, you can always throw that in there to show off your knowledge. QALYs, quality adjusted life years. So let's say one treatment has, for every 1 QALY gained, it costs 17,000, and for the other one, it costs 20,000 for every 1 quality of life year gained. Now, obviously, you're going to pick the 17,000 one because it's cheaper. You're getting more bang for your buck, so to speak. So that's how the NHS deal with equitable distribution of resources. Okay, so that's legal justice, distributive justice, and the last one I said that you didn't really need to know is called rights-based justice. Rights-based justice, putting it super simply, just means we have human rights, so therefore we deserve to be treated fairly in accordance to those human rights. And by me saying that you don't need to know it, it's not me diminishing its value, because in healthcare that's quite literally fundamental to human rights. I'm just saying it's unlikely to be tested in your interview. They're more looking for you to make comments on the distribution of resources or law, pretty much. You don't need to know the laws as well. So in the HIV scenario, you don't need to know the law about whether you're allowed to break confidentiality or not. And most of the time, whatever conclusion you reach in these questions, they're not going to penalize you for that conclusion, but they're going to assess the way you reach that conclusion. Okay, so that's the introduction to the 4 medical ethic pillars. Just taking a step back and thinking about autonomy and beneficence again. I told you I wanted to come back to the best interest standard, and this is me now coming back to it. The best interest standard pretty much means how do we set a standard as to how we decide what's in a patient's best interests. Putting it simply, there's something called the Bolam standard. There's other standards as well, I know. I'm not going to get into a lot of detail because I don't want to waste your time. and this video is long enough as it is already. The Bolam standard, also called the reasonable doctor standard, is a standard in which it's used in court of law. So let's say a doctor does something that the patient thinks is questionable, and the patient takes the doctor to court for negligence, so something that caused them harm as a result of the doctor's action. How do we decide whether the doctor did what was in the patient's best interests or not? We use the best interest standard, which is determined by the Bolam standard. Keep up with me, you don't need to know all this detail, I'm just giving you some background information. The reasonable doctor standard, i.e. the Bolam standard, pretty much, putting it simply, you line up 10 doctors and you say, would you have done this in this scenario? Would you have done this in this scenario? And you ask them all that same question. Depending on their answers, we'll be able to tell what's in the patient's best interests, because any reasonable doctor would have done what you have done in that scenario. So that's how we can decide best interests. As you can tell, it is a very paternalistic view of what's in a patient's best interests. It's the doctor deciding what is in their best interests. Taking a step back and looking at autonomy, autonomy is purely what the patient wants. Purely what the patient wants. There's nothing else to autonomy. Those are two ends of the extreme, right? And we know that the middle ground exists. So the middle ground is what we call shared decision making. You can use that key term of shared decision making in your answer. You could say, I would try and come to a shared decision with the patient, because that would lead to the patient adhering to the treatment plan better, because we came to a concordant agreement. Those are two very key words, adherence and concordance. Concordance means very in line with each other. So you can say a concordant agreement means our views are in line with each other. And adherence means the patient is listening to and following what you've prescribed them, whatever the treatment plan is. So let's say a patient is unhappy with their treatment plan. You try and come to a concordant agreement with that patient. If they agree, you're more likely to have better patient adherence to the treatment. Therefore, better outcomes for the both of you. That is shared decision making, and it is considered the more modern and the better method of making decisions. Now, in certain cases, you could argue for a paternalistic view. That is very unpopular, but if you are brave, you can do so. But jokes aside, that is the difference between autonomy and beneficence, but specifically, not the difference, sorry, the middle ground between the two. So you can throw this into your questions, answering your questions when you come to it, because in reality, you may be like, hold on, can we not just come to a middle ground? Well, that's what it's called. It's called shared decision making. So just to recap the 4 pillars of medical ethics before I move on to the next section of this video. We've talked about autonomy, we've talked about beneficence, we've talked about non-maleficence, we talked about justice. Specifically, we talked about the difference between beneficence and non-maleficence in positive and negative rule, and we talked about the scope. Beneficence is mainly focused on just the patient, what's in the best interest of the patient, and non-maleficence can be widened in its focus to include third-party members, i.e. anyone who could be harmed as a result of your action. They would also be considered under the pillar of non-maleficence. We talked about autonomy and beneficence and that middle ground of shared decision making, and we talked about the 3 types of justice, namely distributive justice, where the NHS use QALYs and they set a limit of £20,000 to £30,000 per 1 QALY. Okay, moving on to capacity. Firstly, what is capacity? Capacity is the patient's mental ability to make a decision regarding themselves. So, or anything in the matter, but in terms of healthcare, regarding their own healthcare. So, the patient's mental ability to make a decision. What can affect the patient's mental ability? Firstly, we look at the Mental Capacity Act of 2005. This is an act that was released in order to help guide clinicians and set in place standards that the patient needs to meet in order to be deemed to have mental capacity. Because clearly, if the patient doesn't have mental capacity, they can't give valid consent, which is what the next thing is we're going to talk about. But let's stay on capacity for now. Mental Capacity Act of 2005. Let me break it down for you. Let's think about it logically so it stays in your memory as well. So think it through with me. What can affect the patient's mental ability to make a decision? Well, firstly, any disorder of the mind or brain affecting them at the time that the decision needs to be made. So that is a section of the Mental Capacity Act. If they have that, then clearly they don't have capacity. Affecting them at the time the decision needs to be made. Remember that, affecting them. So they can have a very mild form of dementia, but still have capacity. Okay? So it's not just that they've got the diagnosis, it's that it has to be affecting them at the time that they need to make the decision. Okay, now there needs to be a way that we can assess if they have capacity. There's 4 simple steps detailed in the Mental Capacity Act, and I just want you to remember these 4 steps, and we're not going to go through the rest of the sections of the Mental Capacity Act because that's way too in-depth for what you need to know. But you need to know whether there's disorder of the mind or brain affecting them at the time the decision needs to be made. That's a mouthful. And you need to know the 4 steps. So here are the 4 steps to assessing if a patient has capacity. 1, can they understand the information you're telling them? 2, can they retain the information you're telling them, i.e. can they remember what you've just said? 3, can they use and weigh the information you're telling them? So can they weigh up the pros and cons of whatever you're saying? And 4, can they communicate their decision back to you? Obviously, if they can't communicate a decision back to you, you don't know what they want, so they lack capacity. If they can't remember what you've said, then they can't make an informed decision. All those aspects make complete logical sense, so I'm not going to bore you with that. Right, so that is capacity in a nutshell. We see if there's a disorder of the mind or brain. We see if we can assess capacity through those 4 methods. Now, if they lack capacity, that's when we need to start looking for other things in order to make that decision. We don't straight away decide for them, okay? There's systems in place just in case someone lacks capacity. So these systems are as follows. First, we look for an advanced directive by the patient. An advanced directive means, in advance, I've made a directive on what should happen to me in the event that I don't have capacity. So an example of an advanced directive is a DNAR form, do not attempt a resuscitation form. So that is them in advance when they had capacity signing a form saying, do not attempt to resuscitate me if I need resuscitation. Okay, that's a simple example. Moving on from that, let's say they don't have an advanced directive. Do they have an LPA in place, a lasting power of attorney? A lasting power of attorney is someone that the patient has appointed to make decisions for them in healthcare and also in financial matters and everything else. One thing to note, if you really want to stand out, is just add on to the fact that LPAs require a lot of time to be put through and to be processed. So you would check if they have an LPA, or you would check if an application is currently in progress. So that's something that you could also throw in there just to really show off. But moving on, so you check for advanced directive, you check for an LPA. If they don't have any of that, then you can make a decision in the patient's best interests. But you make the decision in the patient's best interests according to the least restrictive principle. What is the least restrictive principle? I know I'm bombarding you today, but stay with me. You're nearly at the end. Least restrictive principle means, what is the least restrictive path for me to get the outcome I desire from this patient? So, this is the pillar of non-maleficence. We're trying to do the least restrictive thing to the patient. We're not trying to harm them that much. We're trying to do the least harmful thing to the patient, but still in keeping with their best interests. So if their best interest is to have quite a painful procedure, then unfortunately that might be what's needed in this scenario. So the being least restrictive doesn't take precedence over the fact that you need to, have your duty of care to the patient, to do what's in their best interests. And remember that key term, duty of care, because you have a duty of care to your patients. Okay, so that's capacity. That's the Mental Capacity Act, disorder of the mind or brain, and the 4 ways to assess capacity. Then there's the what to do if they lack capacity, and that's advanced directive, LPA, and then make a decision in their best interests. So that's capacity in a nutshell. I'd recommend applying this to a few scenarios and see how you get on. But let's move on from capacity now to consent. Okay, let's move on to consent. What makes it valid consent? It's a good question. Well, I have a mnemonic for this. So, the mnemonic for valid consent is this. Very old isn't capacitors. Very stands for voluntary, so the consent has to be voluntarily given. You can't coerce consent out of someone, otherwise it's not valid. Old is for ongoing, so the consent has to constantly be ongoing. It's an ongoing thing. It's not just that they sign a form once and that's it. They're doomed to have this procedure. They can withdraw that consent at any time. that being able to withdraw the consent means that it's ongoing. So you need the consent to be ongoing for it to be valid. Isn't stands for informed. So the consent has to be informed fully of the risks and the benefits of whatever it is you're consenting them for. Capacitus, and we just talked about capacity, so capacitus means the patient has to have capacity, and we talked about how to assess that as well. See if you can remember it. So we've talked about the 4 pillars of medical ethics, we've talked about consent, and we've talked about capacity. Now the last thing on our list is confidentiality. Confidentiality is exactly what it says. You are bound by duty and law to maintain doctor-patient confidentiality. What does this mean? This means that whatever the patient says to you is strictly confidential between you and that patient. So this gives the patient trust in a doctor. Otherwise, patients wouldn't come to us with issues. So when you're talking about the doctor-patient relationship, confidentiality is extremely important. And I want you to make note of the doctor-patient relationship as a key term, because you can refer back to this in nearly every interview question that you answer. And the doctor-patient relationship, especially trust between the two of them, is extremely important. And that is primarily resting on the fact that there's confidentiality, a duty of confidentiality between the doctor and the patient. However, there are moments and certain scenarios where you're able to breach the duty of confidentiality and breach the doctor-patient confidentiality. Now, what are these situations? Well, putting it simply, there's a few scenarios and I'm going to list them for you. So, the first one is if there's harm resulting to a third party if you don't break confidentiality. An example of this could be COVID-19. Let's say you have a few housemates, one of your housemates gets COVID-19, tests positive for it, automatically the rest of you are alerted about that. Now you might know, or you might have a sneaking suspicion about someone might have had COVID in your house, but now that you've been alerted, that confidentiality between the person who was initially tested positive for COVID and their doctor has been breached, because the doctor is now told their housemates, i.e. you, that they have COVID-19. Now, this has its implications. Obviously, COVID-19 is one example, and I think that was quite normalized at the time. But there are other examples as well, like the HIV patient that I told you. That could be a scenario where you breach confidentiality, because you're allowed to breach confidentiality in that scenario because of that stipulation of there's harm to a third party if you don't breach it. So that's one example. Another way or scenario where you might breach confidentiality is if a serious crime has been committed, and I'm talking something like murder, where the police need the details of a patient. Now, you give the police only up until necessary information. You don't just hand all the medical records over. Let's say they need a patient's address. You give them just the address if there's been a serious crime committed. And this does not apply to petty crimes. And by petty crimes, I'm talking like stealing a car. This doesn't apply to that. It has to be a serious crime in order for you to breach doctor-patient confidentiality. That's how serious doctor-patient confidentiality is. So you have to vet when the police is asking you for information whether you're willing to breach doctor-patient confidentiality. It's your choice, not the police forcing it on you. Okay, and the other scenario in which you can breach confidentiality is in the healthcare team. So let's say you need to discuss a patient with a colleague because you're struggling with the diagnosis or management. Then you're allowed to discuss the patient's details, history with that colleague, because it's for the patient's treatment. It's part of the patient's treatment plan, so you're allowed to discuss. For teaching purposes, you got to anonymize the information, and it's also good practice to ask the patient for consent, even though you've anonymized the information. That's good practice, but you don't need to. You don't legally need to ask the patient for consent if you're using their information but anonymized, so nobody can tell it's them. But if they can tell it's them, then that's on you. That's your fault, because you haven't anonymized the information properly. Okay, so that is just a quick overview of confidentiality. Main things to know is harm to a third person and serious crimes being committed, and then within the healthcare team. Those 3 scenarios you can breach patient-doctor confidentiality. Otherwise, you never do, because it harms the patient-doctor relationship and the trust that comes along with that. So, Thank you for sticking to the end. It's been a whistle-stop tour of medical ethics. There's also a bunch more things with regards to moral schools of thought that you can read on. I'm going to give you some homework at the end of this video. Go have a look at consequentialism, deontology, and hedonism. Look at those 3 schools of moral thought and try and apply them to medicine and find scenarios in which they're applicable in medicine. If you are struggling with that at all, drop it in the comments and I'll explain it. But other than that, that's medical ethics done. It's an immensely dense topic, and even just this video and making notes on this video alone isn't enough. You're going to need to practice this multiple times and apply your knowledge. If you want someone to guide you through it one-to-one, i.e. myself or someone else from the MedCamps team, feel free to check out our website and check the packages that we have on offer. Likewise, if you want someone specific to guide you from our team, then just drop that in your order details and that'll get sorted out too. Including myself, you can request me directly. So yeah, good luck with your prep and I'll see you in the next video. Peace.